Well, over the past couple days, you've seen quite a bit of Dr. Gary Lemon and Dr. Lila Marabi. They have been serving as associate medical directors over the past couple years, and their term is unfortunately coming to an end. We want to thank them for their service and dedication to the VQI. Their contributions were significant and set a great foundation for future AMDs, and most importantly, they made my life a lot easier. Beyond all the standard committee meetings such as the EC, the RAC, the regionals, Gary and Lila have made significant contributions that will leave an imprint on the future of VQI. Some of the achievements that I'd like to highlight include the following. Gary really developed the Fellows in Training program and made it what it is today. This has been extremely successful and helped nurture future leaders in vascular surgery and VQI. His passion for quality improvement has also led to the creation of our new Smoking Cessation National Quality Initiative and multiple improvements in VQI reporting measures. Lila brought us a depth of knowledge and in healthcare, informatics, and analysis. With her expertise, she has helped lead the VQI's data automation efforts with EPIC. She is also has been involved in working to integrate Delta, the digital extraction longitudinal trend analysis technique, open source software application into VQI. She has become an extension of the PSO's analytic team, providing support and guidance to the PSO staff. So a big round of applause for Lila and Gary. A bittersweet moment. So we have recently been working on developing an app for VQI. Given the challenges of firewalls, blocking emails, and the high volume of all the emails that we all receive on a daily basis, the PSO has been in the process of developing an app for VQI. Phase 1 of the app development is targeted providing an alternate communications vehicle to push important messaging to VQI membership. We will be focusing on improving our communications around regional meetings, notification of report availability, and annual meeting updates. In addition to improving communications, the app will also provide quick links to tools and resources such as the VQI risk calculators, data cutoffs for reporting and publications based on VQI data. We expect that this initial phase on app development will be completed towards the end of 2024. Future considerations for the app would require single sign-on integration with pathways to potentially provide reporting on mobile devices and the possibility of data entry. So we think this would be a significant enhancement, make it a little bit more user-friendly for everybody, and we're hoping to launch it by the end of this year. So finally, I just wanted to express my appreciation. Also, the meeting has been tremendously successful so far. We're not done yet, but we do appreciate the contributions of all our membership. And at this point, I guess I'll pause to take any questions or comments about the FIT program, the national update, or the app. All right, well, we're running a little bit ahead of schedule, but do we have everybody here from the panel? I see Greg, I see Olamide, Shipra, is Shipra here? All right, yeah, great. So why don't we just go ahead with our panel. We're running ahead of schedule, which is terrific. So let me call all of the panelists up to the front for our disparities panel. So while they're coming up, I would like to introduce our first speaker. Known to many of us, a good colleague from the FDA is Greg Pappas, MD, PhD. He has a leadership role in the FDA involvement of the Biologicals Evaluation and Safety System. He has extensive international experience working with WHO, USAID, and the CDC. He has served as professor and chairman in the Department of Community Health Sciences, Aga Khan University. He has been senior policy advisor to the Assistant Secretary for Health Surgeon General. He directed the Office of International and Refugee Health, HSS. And he is going to be speaking to us about racial and socioeconomic disparities in peripheral artery disease outcomes. He has a long-standing interest in this, and his expertise is recognized on having published a paper on disparities in healthcare in the New England Journal of Medicine, I think over 20 years ago. He's a great supporter of registries and real-world evidence, and it's a pleasure to welcome Dr. Pappas to the podium.
Thanks so much. It's really an honor to be here and speak to you today. Let me see how this works. Oh, here, okay. Yep, nothing to disclose. This is not a formal FDA presentation. This is a scholarly effort on behalf of a group of individuals. I'd like to thank the team and the co-authors, many of whom are here. Very robust group of both vascular surgeons and other scholars working on this project. Here's a kind of an overview on what we're doing. Basically, I'm going to present to you a protocol of a study that's underway. This is an early report on analysis. You all have a deep understanding of the issues that are at play here. And what we're basically trying to do is understand the time trends in racial and ethnic disparities in outcomes in vascular surgery. The work has been done on a cross-sectional basis, and we're basically from a methodological perspective, starting with Dr. Arias Chipra's analysis using the VA data, which demonstrated very clearly these racial and ethnic disparities, controlling for as many variables as they could come up with. Really quite an excellent. But we don't know how that dynamic, how that disparity has played out over time. So we're doing two things. We're applying that analysis, first of all, to national data. We're using the VQI and the Vision database as opposed to the VA data, and then we're looking at it over time. The broad objectives are to contribute to the literature on racial and ethnic disparities that you know a lot about, and beginning to ask some questions. I'll return to this about if the VQI is mitigating any of these disparities. We'd like to think, we hope, that these disparities actually are declining over time. However, as Jens mentioned, I've been looking at this issue of disparities in time trends for many, many years. And we find, sadly, that many public health programs, clinical programs that are pitched towards the general population end up increasing disparities. That is, the people who are perhaps most in need, or people who are disenfranchised, have disability, social disabilities, don't benefit from those programs. We're also going to, so that might end up in an initiative, a focus, a targeted initiative to address, depending on what this analysis tells us. And of course, the cardiologists have done a similar kind of exercise, not with the time trend analysis, but they actually have a national initiative to address the disparity specifically, as opposed to address the population in general, and hope that everyone comes along at the same rate, which, as I said, isn't always the case. The other objective is something I personally bring to the table on this one. I want analysts at the FDA to get their hands on and touch and understand the VQI data. I'm trying to bring it in-house. And this is because I'm trying to develop, this is my main job, this is my day job, trying to promote real-world evidence at the FDA, which sounds like it should be easier than it is, but it's actually been quite a challenge. And as many of you know, there are biological products in the pipelines for y'all, for the vascular surgeons. And I started out my career at the FDA at the CDRH and working on devices, and now I'm in biologics. And it would be a pity if the FDA begins to regulate these biological products and doesn't engage the Vascular Quality Initiative. So by having some young, bright analysts at the FDA that have actually looked at the data, have touched the data, have interacted in a very pragmatic way with the leaders in the field, and what an honor for us. It would be a pity if we didn't have the opportunity. So the protocol has a number of objectives, and I'm sure that the co-authors be happy to share the protocol. We're almost done with the formal protocol. We're still kind of finalizing it, but the primary outcome is to, as I said, to analyze those temporal trends in race, ethnicity. As in the past, we've tried to control for other social determinants of health, the socioeconomic status as best we can with the place variables, based on zip code, a recode to give it a sense of urban-rural nature of the place the patients come from, and also the social and economic status of the effort. We're also, so we're going to be looking at the outcome for the postoperative major amputation rates for patients. We're also going to be looking at, for a secondary outcome, we're going to be looking at postoperative outcomes, other postoperative outcomes of peripheral arterial disease. And as an exploratory effort, we're going to try to begin to address bigger questions about program evaluation. So the secret, the thing I'll share about myself, and that my PhD is in anthropology, and so I'm a social scientist, and program evaluation is something that's very interesting to me. So how can we position this? First of all, I have to say I'm so deeply impressed by the work that's been done by this Vascular Quality Initiative and the contribution that you've made to the health of your patients. From a broad public health perspective, it is a pity that we don't have something like this across all specialties in healthcare. The good news is that it's happening. It's beginning to happen. Most specialty societies at least have the idea or a plan for a registry if they don't have something ready yet. But getting there is going to take a lot of commitment, and I think a lot of federal and private sector investment, which isn't there yet. So for me, as a Fed, someone who thinks about Congress a lot, trying to convince policymakers and funders of programs that quality initiatives work is a very important exercise. It's not just an academic exercise. It's to show the robustness and the impact of these activities. So that's something we're going to try to do. We've got a couple new ways to do this. We've got a timeline. We're in this initiation phase. I think in the next couple weeks we're going to finalize the protocol. The type of analysis, as you know what it looks like. We're going to be doing some simple cross tabulations and then some time trends that's well controlled. And this is not real data, but to give what we're going to be looking for. Oops. Whoa. And as I said, this gets into the weeds a little bit, but we're going to look at some of the process measures, both as outcomes, that is success of the program. If the VQI document that it actually changes process measures. Are patients on their medication? Are patients getting their pre and post procedural assessments? Are they getting referred to smoking cessation, chlorhexidine maybe? We're still thinking about that one. These kind of process measures are success measures in themselves, but then they're also intervening variables in the broader analysis of outcomes. So this is where we're going on that. And I think I've said most of this already. We're going to look at these various. Yeah, I think I've said all these already. The one thing I'd like to add here is that another utility of this that I think may position the vascular surgeons at a higher level of recognition, which I think they're due, is to use these measures as part of Healthy People 2000. So the HHS sets national goals for the nation, and but it's very much evidence-based. They have to have the measures. You all can provide them with those measures to see how the health of the nation is improving. So this is another objective that I have personally to work with you all. So with that, I want to, again, thank you and tell you what a true honor it is for me to work with y'all. I started this journey with me and Jack, trying to figure out. I was very impressed with the many decisions that were supported by VQI data. This is regulatory decisions around the safety and efficacy of medical products. And we were able to document that that VQI saved a huge amount of money. There's like 200% return on investment, years of time saved, and better data. So it's good to save money and get less time. It's good for industry for sure. It's good for patients too, because they get products that we're confident with early on. But as a public health doctor, the better part is important. And as much as I love the FDA, and what an honor it's been to work there at the end of a long career, the quality of the data sometimes is not very impressive. 250 people in a clinical trial is like, we're not getting at racial and ethnic disparities. We have hundreds and thousands of records that we can evaluate the safety and efficacy of these products in ways that just aren't possible. So the better part. So at the FDA, my mantra is I'm the better, faster, cheaper guy. So, but it's the better part that really has compelled my work. And again, I want to thank you all. I want to thank the leadership, and looking forward to moving forward this initiative as we go forward. Thank you.
Thanks very much, Greg. And what we'll plan to do is have Dr. Levy give her talk, and then we will open it up for questions and a panel discussion. Dr. Levy is a vascular surgeon at Emory University. Her research efforts focus on peripheral arterial disease and studying disparities in access and treatment. And we were pleased to have her as the chair of the IVC Filter Committee, where she's starting some new initiatives. And she's going to be talking to us about the racial and socioeconomic disparities in peripheral arterial disease outcomes, a temporal analysis of VQI vision data.
Thank you. And I don't know what time it is. Good morning, good afternoon, everyone. At this point, I don't remember what time it is. Okay, so I'm going to give a little bit of context to the problem, why that problem is still relevant to discuss today, how we've leveraged data with VQI data specifically to better understand the problem, and how transformative this collaboration between the VQI and the FDA can and will be. So again, I'm Olamide Alabi, one of the vascular surgeons in Atlanta and at Emory. No disclosures. So We've all seen this data before, facts like this. So there are over 12 million individuals in the United States who have peripheral artery disease. These are actually old estimates. More contemporary estimates would suggest that it's somewhere between 20 to 25 million at this point using similar methodology. So the overall prevalence of peripheral artery disease ranges in reports between 3 to 10%, probably closer to like 10 to 12% at this point. We also know that the prevalence of peripheral artery disease increases with age. There are several known risk factors for peripheral artery disease, as you can see this non-exhaustive list here. We typically concentrate on those that we know quite a bit about. So age, it's a disease that increases with age, smoking status, diabetes, and chronic kidney disease. We have identified race as a risk factor for peripheral artery disease, as well as subsequent lower extremity amputation for many years, decades, in fact. However, we have no idea why that is, particularly since race is a social construct. And to be quite frank, very few have used rigorous methods in an attempt to figure out why race is a risk factor. So why does any of this matter? Again, not exclusively, but peripheral artery disease is a disease of older adults. There are populations of patients with symptomatic peripheral artery disease who have a risk of limb loss that ranges anywhere from a very low number to a very high number. And this mostly depends on who you are, where you live, and where you are on that spectrum of disease when you present to a vascular specialist. So with all that said, over 185,000 major amputations occur each year. And about 2,000 of those occur within VA hospitals as well, or to veterans that get care within a VA. About 2/3 of individuals who undergo major amputation have diabetes, and just about half of individuals who are undergoing major amputation are of a race, or identify as a race other than white. Several studies have shown that the rate of amputation within the Black community with PAD is 2 to 4 times that than the white community with PAD. Black patients have the highest prevalence of peripheral artery disease, perhaps maybe only rivaled by Native Americans in one particular study. It is 2 to 3 times that of non-Hispanic whites at any given age. And compared to Black women, brown women are a close second in all age groups. As far as outcomes go, Black patients are treated differently when they present with symptomatic PAD and experience worse outcomes related to their PAD. So when people ask the question, well, do disparities in peripheral artery disease presentation, care, and outcomes exist? The answer is yes, they do. For example, statins, we know that statins save lives and they save limbs. But Black patients are less likely to get statins when they're eligible for them. We know that exercise therapy is standard of care initial treatment for patients with non-disabling claudication. However, Black patients with claudication experience a greater degree of functional decline than white patients with claudication. There's data from the CLEVER trial as well that shows that exercise therapy has a greater impact on self-reported quality of life in Black patients with claudication compared to white patients with claudication. However, we all know that everyone who needs exercise therapy isn't getting exercise therapy, particularly people from structurally disadvantaged communities. So again, in a group of people who largely should be offered non-operative management first, Black claudicants in low-income counties have a 30% increased likelihood of getting a peripheral vascular intervention than white claudicants. And risk factors for late interventions in a group of claudicants include Black race and early revascularization, which again, may sometimes, but not always, be an inappropriate revascularization. We also know from this study that early PVI in claudicants leads to progression of chronic limb-threatening ischemia at higher rates compared to when early PVI is not performed. So VQI data was explored for this particular study from UAB, our UAB colleagues, and Black patients are more likely to get vein mapping before a lower extremity bypass, but they're less likely to have vein used when they get a lower extremity bypass. Single center data, multi-center data, big data from Medicare, they have all shown us that Black amputees are less likely to get revascularization before an amputation. And for those who do unfortunately have to have a major amputation, Black patients are more likely to get an above knee amputation as opposed to a below knee amputation, of which an above knee amputation may have a higher and faster healing rate. However, it also has a higher mortality rate and lower likelihood of future function. So has anyone ever counted the number of publications that there are on the topic of racial and ethnic disparities in peripheral artery disease? This is not the total number. It's just when I got tired of putting these things up. So, that number, it's not few, and this body of work stretches across decades, as previously mentioned. So despite this, the amputation epidemic, where Black and brown patients with PAD are at 2 to 4 times higher rates of major lower extremity amputation than white patients, certainly still exists in this country. Several large organizations have called for an elimination of this problem. Others have created multidisciplinary collaborations or consortiums to talk more about this problem. But the one thing that no one has done is solved this problem. So largely, not much has been done about racial disparities in amputation or this amputation epidemic at all thus far. So, I and several others have dedicated our academic careers to studying vascular surgery, particularly peripheral artery disease and quality. And I believe that racial disparities are the greatest threat to quality. And that without solving this problem, it will be quite difficult to solve really any of the problems that plague this disease space. We've done quite a bit of work to try to better understand the patient perspective and health status or patient-reported outcomes among patients with peripheral artery disease, particularly those with chronic limb-threatening ischemia. We've also done a lot of work to better understand quality metrics. For example, when we look at things like readmission and reintervention, we often use a 30-day perioperative outcome window because that's what we've been doing for years and years. NISQIP has done it, et cetera. So that's kind of how far we've always looked for when these kind of events happen. But we know with peripheral artery disease in particular, events occur still at high rates after 30 days. One particular study actually found that the rate of 30-day readmission for patients was about 25%, but when they looked between 31 and 180 days, they found that 48% of individuals were readmitted to the hospital after their PAD revascularization. There's been a lot of focus on how we can move from a fee-for-service to a more value-based care model. They've done this in a lot of different disease spaces. It hasn't touched peripheral artery disease or vascular surgery just yet, but I would say that it's coming. So our work leveraging the VQI data linked to Medicare claims data, or the vision data set that we talked quite a bit about over the last couple days, we looked at this over a 9-year period and showing that among a group of over 40,000 individuals who undergo PAD revascularizations, 18% of them were readmitted within 30 days, and about 31% were readmitted within 90 days. We also pivoted our focus to look at 30 and 90-day reintervention. We found that the age-adjusted proportion of patients who were readmitted or reintervened on in 30 days after a lower extremity revascularization was 5.5%, and that rate was 14.5% at 90 days. So taking this a step further, we have evidence in other surgical specialties that readmission care fragmentation is bad for a number of reasons. However, we don't know much about what this means in the PAD space. So if you have a lower extremity revascularization, you leave the hospital, you have to come back and get readmitted to a hospital, but perhaps you get readmitted to a hospital that's not where you had your original procedure. Does that affect your outcomes? So we look specifically at that using vision data. And we found that of these individuals who had to be readmitted, over 1/4 of them were readmitted to a non-index facility. And while readmission to a non-index facility was not associated with the outcomes that we were interested in, mortality and amputation, as well as at 30 and 90 days, we did find that if you're readmitted for a procedure-related issue, and particularly to a non-index facility, that is associated with worse amputation at 30 and at 90 days. We also looked at reintervention care fragmentation. So you have your lower extremity revascularization, you leave the hospital, you have to have a reintervention for any number of reasons, and you have that reintervention at a facility that did not do your original revascularization. So we did find that reintervention at a non-index facility is associated with 90-day and 180-day amputation. We found that these people who have to have these reinterventions and they go to a non-index facility, they're more likely to be Black. These patients also are more likely to have a history of heart failure, diabetes, be on dialysis, and have a history of prior amputation as well. We've dedicated quite a bit of time to better define and describe practice patterns when it comes to process measures. We talked a little bit about some of these things that we've done here. Phil Goodney, he did a lot of work to better define what was happening to patients in the year before an amputation, how aggressive or how not aggressive care is for those patients. And he used Medicare data to do so. We used vision data to better understand that. We used VA data to better understand that in the VA setting. And while in the private sector, about 46% of individuals in the year before an amputation were getting a revascularization to try to save their legs before this amputation occurred. In the VA, about 70% compared to that 46%. So 70% within the VA get a look at their blood flow or an intervention to improve their blood flow before that major amputation. So I think it's important that we find good models of care by which we can emulate, and we can use vision data and more to better understand those types of things. And lastly, I'm going to talk a little bit about PAD pharmacoequity. Pharmacoequity is a relatively new term. Over the last couple years or so it was coined. But let me say this very clearly. So guideline-directed medical therapy, we know that guideline-directed medical therapy, which, you know, at the very bare bones of it, you can say is antiplatelet therapy and statin therapy. We know that this can save limbs and this can save lives. But as you can see, most people do not get guideline-directed medical therapy. So if chronic limb-threatening ischemia is a disease where how you start matters, meaning the severity of disease on presentation can be a significant driver in terms of outcomes, then early guideline-directed medical therapy can change where you finish. So this is more than just medications at discharge. We have looked at VQI quarterly reports, and largely due to the efforts of our quality manager, Alexis Neal, we have a discharge medication rate of 100% and have for several years. But when we looked at our patients who had major amputations in the year within our healthcare system, in the year before that major amputation, only about 1 in 4 individuals were on the right medications. So again, if CLTI is a disease that is largely influenced by how you start, then early guideline-directed medical therapy can change where you finish. And so we as vascular surgery team members and just team members within our quality groups as well, we're all leaders. Given the gravity of the problem, this amputation epidemic, the proceduralists cannot simply be technicians. So I give talks to students all the time, and we say that we vascular surgeons are the ones who are running towards the problem while everybody's running away, right? So we're the ones who want to try to fix the problem while others are kind of looking around and don't really know what to do. So if this is going to happen, we're going to have to be at the table, and for many large parts, we're probably going to have to helm this effort to improve the initiation of guideline-directed medical therapy at the start, so we can change how our patients finish. So in summary, racial and ethnic disparities exist in PAD prevalence, treatment, and management. These disparities are not based on biology alone. These disparities are not a reflection of genes or one's genetic code alone. I think it's important to see patients as people, and we often present research and quality metrics, et cetera, at this kind of high-level view or an us versus them kind of a perspective, but these categories are communities. They are our patients, but from all intents and purposes, they're our family members, our neighbors, our friends, and they desire to have futures. So I think that this collaborative effort between the FDA and VQI can truly be transformative. We can examine amputation disparities among PAD patients and assess changes over time, as mentioned. We can examine process measures that are captured already within the VQI in our patients who undergo amputation, and determine factors associated with receipt of appropriate process measures. We can be sensitive to intersectionality and be the first study to define amputation rates, time trends, and risk by the intersection of sex and race. And we also have an opportunity to use this data to be strategic and intentional in our future efforts as an organization to develop an intervention that utilizes VQI data reporting as a mechanism to provide race and ethnicity-specific audit and feedback reports to our VQI participating proceduralists as well as VQI participating sites, such that this amputation epidemic can finally be eradicated. So I look forward to working together with the team, many of which are up here, but there are several others also. Hopefully I didn't miss somebody, but mostly listed up here. And we're happy to take questions.
Thanks. That was a great talk. So we've assembled a rather august panel, and before we get into it, I would like to introduce the other panel members. Down at my far right, we have Dr. Cockrell Hughes, MD, PhD, Professor of Surgery and Chief of the Division of Vascular Surgery at Howard University and Hospital. His primary interest focuses on sociodemographic disparities in peripheral vascular disease, and he serves as assistant editor at the JVS. Next to him, we have Dr. Matt Corrier, whose introduction I just misplaced. Dr. Corrier is a professor of surgery and head of the Division of Vascular Surgery at The Ohio State University, where he also serves as director for the Vascular Surgery Fellowship Training Program. His research focuses on survey-based patient preference elicitation, patient-doctor communication, risk stratification, and integration of clinical and patient-centered outcomes. He has received research support from the AHA, US FDA, and many other sites. Next in line is Dr. Phil Goodney, vascular surgeon and health services researcher at Dartmouth. He's vice chair of research and director of centers for the evaluation of surgical care at Dartmouth. His many interests include clinical trials, patient preferences, and shared decision-making. He's received a Career Development Award from the NHL BI and has served in many capacities for the VQI, for which we're grateful, including many years as chair of the RAC committee. And next, we have Dr. Shipra Auria, professor of surgery at Stanford University School of Medicine and section chief of vascular surgery at the VA Palo Alto Health Center. She has a master's degree in epidemiology from Harvard School of Public Health, and her focus and research is on methodology in cardiovascular epidemiology. She's been funded by the AHA and has also done work in frailty research. So maybe before we open it up for questions, I'll put all the panelists on the spot to make a few comments, and maybe start with you, Dr. Hughes, to make a few comments on the presentations that we've heard so far.
Well, thanks very much, all of you, for coming here to listen to these presentations. We are very grateful to the partnership, very grateful for the partnership of the FDA, and we are pleased that the FDA is willing to partner with us. Look forward to answering your questions. We think this is an important area of research, and we are looking forward to interacting with you and see what you all will have to help us along the way. Thank you.
Dr. Corrier.
I thought Alamede's presentation, resonated. All those studies. I feel like this disparity issue, we're really good at describing it, and we run a little bit of a risk of messaging that it's not a solvable problem, because a lot of physicians kind of feel like, I feel like it makes me sick when I see a new patient through the emergency room with bilateral foot gangrene. Happened Monday this week for me. And we really need to start thinking differently, not only about how we take care of the patients we operate on, but how we get out in front of this to patients before they get gangrene, and how we get out to children of patients in the situation to get ahead of this problem. And I do love vascular surgeons leading the charge, so I'm right behind you, Alameda.
I like to think that we're all standing right next to each other. I already spoke a lot, so I think I'll just kind of reiterate a couple things. As mentioned by Dr. Pappas, these quality improvement initiatives that go forth for various different issues, they're good, right? We know that they're good. We know that they certainly can have high impact within our health systems and also for our patients. But when we employ these to the general population, there should be no expectation that it will fix it for the people who are most impacted, particularly in a disparate way. We've seen over and over again that it just doesn't happen for those communities. I think I'll also reiterate one other thing. CLTI or PAD kind of in general, it's a disease that it really matters where you start, right? And if we know that there's something that we can do to change how people finish, I would say that at least one of those things is early guideline-directed medical therapy in patients before they show up in the ER with bilateral leg gangrene. We just need to find ways that we can change the way that they finish.
I'll second Dr. Corrier's endorsement of Dr. Alabi's nice description of the project, and also share my appreciation for Dr. Pappas's investment of the FDA's enthusiasm here. And I'm very excited about this work. This is you nicely showed, Lamide. We've written about it for a while, but our next steps are to make forward progress, and you need a sort of a bit of a megaphone to help with that. The FDA's efforts certainly should provide us that. And I think, I'm hopeful that, efforts around sharing data made me very appreciative and grateful to see your work that leveraged our linked data sets. Jens and Jim and the registry have been very supportive of developing that resource, and this is exactly the type of research that I hope that our data linkages would help to inform, not just the short-term results of treatment, but where long-term disparities need to be identified and then mitigated. And who better than this sort of large team of people with a lot of experience and input to try to make some forward progress. So, one of the things I've most enjoyed about the VQI over time is the spirit of collaboration and sharing, even when the topic seems very, very difficult, which this obviously is, but you got to start somewhere. So I'm excited about this work.
I echo everybody's sentiments here. I think most of my thoughts have already been relayed. I'm just very excited about this collaboration. I think having policy and data kind of come together in a way where we can actually make a difference, I think that is going to be very powerful. And as Dr. Alabi mentioned, we as vascular surgeons run towards the problem. There is more recognition about this now that, we see some policy statements and collaboratives coming from the cardiology and interventional groups, as well as they're realizing like how bad of a problem this is in terms of disparities. But we are still sort of ahead of this. We've been doing this for much longer, and the rest of the community of vascular interventionalists and vascular medicine folks are just now sort of coming to the table. So I think we still have the most experience and subject matter knowledge about this. So we should leverage the registry that we have, and the linkage with Medicare, I think, is a really powerful tool for us to really look at where our interventions can have the maximum impact. So I'm really looking forward to that.
So, as has been pointed out, one of the ideas behind this study is to not only look at the current status of disparities, but to look at temporal trends. Has there been a change over the past 10 years or over the past 20 years? And the one other thing that we would like to look at is, does participation in VQI make a difference? Does a patient coming into a VQI center? Because I think that would be very informative of us to know if it's having any impact or not. Certainly, if there are any questions from the audience, please step up to the microphone. That's the idea behind it.
Can I ask a question of the other panelists?
Please.
Because,
Sure.
I mean, and there are several on the stage here who've written about sort of the effect of the system that the patients live in, whether you're in a single payer system like in the VA or in a country with single payer options where access theoretically should mitigate some of these disparities, but it doesn't go away. So I wondered if some of the folks, because if we think about, well, what does VQI offer? It offers, a chance to make sure that it's high quality vascular care can be delivered, and transparency is important. So theoretically, that should help those who reach care. But how much does that sort of affect at designing a safety net, contribute as compared to a broader safety net that encompasses all the medical care that's provided for that individual?
May I respond to that from a social science perspective? So this is something I think a lot about. So without being controversial, you can think of social determinants here in 4 different categories. One would be the direct experience of the patient, the doctor. I mean, I hate to say it, but some doctors maybe are racist, so there's that. So there's a differential experience. Then there's policies of institutions. And that's usually called structural racism, and we were aware of those things. Then there's broader social, the lived realities, and this is where the VQI really has the most difficulty regarding data, because we don't have a lot of information on the lived experience. We've got the 2 measures of area, which are rough proxies for social determinants. And the fourth then would be some genetic residual, which we haven't found much evidence for. But the social determinants piece, the everyday living issues are going to take a lot of special studies, and heartening that the NIH is beginning to take that research set of research questions seriously.
Dr. Cronaway.
Well, a couple comments. First, this is a really, it's an important study, and it's even more important that this is on the program of this meeting. So congratulations for that. You know, when we think about these issues as specialists, you know, we have control over how we treat these patients, and there are certainly things we're going to learn from this study. And as Phil just pointed out, what we don't necessarily have control over is where the disease starts. When we first see it, it may be too late. So one plug for the vascular medicine consult registry is that if we had a lot more data in that particular component, we'd be learning a lot more about where these patients start. But my specific question, in some ways challenge, I guess, for the panel is, if we were to go away from this meeting today, not having all the information yet, but we wanted to start a quality initiative, national quality initiative right now to address this problem, what would that be?
Well, let me make a comment. I think we have some evidence to show that access is helpful. You know, my group, we just put out a paper 2 or 3 weeks ago looking at the Maryland State Inpatient Database, and we look at the period before the ACA 07 to 09 and the period after the ACA 18 to 20. And we are looking at people coming with critical limb-threatening ischemia and the likelihood of being revascularized. And you find out that if you look at the period pre-ACA, it's about twice as many individuals, I think 43% versus 77%. First episode of treatment is revascularization compared to amputation. We are looking at the incidence of amputation increasing by, revascularization by odds ratio of 4.7. And this happens across all demographic categories and all socioeconomic status. So that's sort of that one little study. Now, I wasn't thinking much of it when I started the paper. I should have sent it to JVS, but my fellow presented it as some other paper, so it got published in American Surgeon. But just access only, that's one little thing to show that just access only is leading to sort of floating our boat, people being more likely to be revascularized potentially than be amputation. Now, again, this is only the state of Maryland, so I don't know that this necessarily generalizes to everything else.
I can add something here to Jack's question about, you know, what could we do today? I think VQI has already sort of prioritized some of the, you know, guideline-directed medical therapy issues around use of antiplatelet and statin. So I think places which are not meeting those criteria, centers that are not meeting the greater than 80 or 90% benchmark that we have, I think that's one place to start. I love the smoking cessation efforts that are coming forward. I think that's another area that, you know, PAD has a PR problem. Patients don't understand that PAD is not just, you know, limb threatening, but also life threatening. And I think smoking cessation and guideline directed medical therapy are two most important things we can do for our patients besides revascularization when they come in. So I think just getting us all to focus not just on the surgical part, but also the holistic, comprehensive management of the vascular disease is the basic minimum we could do today for all the patients that we come in contact with. And VQI has already been sort of at the forefront of championing those causes.
I think
I'm sorry, go ahead.
I think if somebody asked me that question 5 years ago, my answer would have been completely different. Because I thought more about this, you know, how can I do this operation better? What balloon should I use? You know, does it need to be drug coated? Should I use skip incision? You know, like things like that. I was thinking so much about what the interventionalist, do to this patient. And now I think kind of where my frame of reference is, and it goes back to that, you know, CLTI is a disease that is largely driven by where you start. And so I think the biggest impact that we can have, and not even just VQI, but I think as a society, I think the biggest impact that we can have is developing a tool, not the ABI, a tool that can democratize screening on a population level for patients, for patient caregivers, and providers alike, organizations like faith institutions, et cetera. Because if we have a tool that is simple to use, that a patient can use at home, that a patient caregiver or family member can see their loved one during Thanksgiving and say, I think there might be a problem, and figure something out together and get to where they need to go before there's actually a severe problem that you can't fix anymore. I think that's where our approach needs to start.
Short, maybe controversial. I'd love for them to just de-risk saving complex revasc. You want me to not amputate this patient's leg? If I hear the devil on my shoulder is this readmission variable, I think readmission is a horrible outcome for somebody who walks in the door with foot gangrene. If you want me to do staged amp and get podiatry to help me do tendon releases and go for the 3-month save to keep this patient's leg on, don't punish me for readmission, and don't get into providers' heads, because the easy way sometimes to avoid a readmission is doing above-knee amputation on that patient. That's a wrong thing a lot of the time. So we also have to be aware of unintended consequences of the way we think about some of these measures in CLTI folks in particular.
Well, if you want to avoid readmissions, you should not take care of peripheral arterial disease patients. We saw in a presentation earlier this morning that the 30-day readmission rate in Rochester after amputation was 24%, and after revascularization it was around 21%. So this is a bunch of bad actors. One thing I would like to add is that last year we started a program, a couple of us, with the SVS Foundation to bring vascular care to underserved communities. We're well aware that there are folks who travel overseas, medical missionary work, students, residents, attendings. You don't need to go overseas to do good work. We started 3 programs here in the United States. 2 of them are in the plenary program this year at the SVS. One is on Joe Mills, serving underserved diabetics in Houston, and the other is from Oklahoma, serving a Native American population. So, I think we need to do more of that in this country. Adam.
I was just going to add to actually what Jack just said, and Olamide actually just started to touch on an answer to this, but there's an old Chinese proverb that says that good doctors prevent disease, mediocre doctors treat disease before it is evident, and bad doctors treat full-blown disease. And we basically spend our whole careers as bad doctors. That's what we do, is we treat. By the time we see these patients, the die is cast a lot of times. And if we're going to measure our success based on how PAD looks right now and how it looks in 10 years, we're going to look like a failure because diabetes is rampant. Uncontrolled hypertension is rampant in this country, especially in Black Americans, and they're not getting access to care and doing things that we can do. And what you just said, Olamide, I think is really important. We need to start thinking about how do we get involved more on a local and regional level. And what's kind of neat about the VQI is that we're already divided into regional groups, and we know the surgeons very well and some of the medicine doctors very well in these communities. And so I think maybe as an organization we could think about how we can start acting on at a level that's well before we usually interact with these patients.
I make a comment about the screening part. I think that's really important because to recognize the disease early. We're still stuck with a bill on screening in Congress that has not been approved yet. And I don't know where and when that will make the rounds and be approved. But even patients who, we have to think about more innovative solutions. And I know there are researchers working on that. Dr. Elsie Ross, one of our former faculty at Stanford, now at UC San Diego, has looked at early identification of PAD through electronic health record data mining, just using AI algorithms to see if we can just pick up PAD early and put them on guideline-directed therapy. We are currently, my T32 resident, Dr. Faradouni, is working on a calcium score. Like almost every patient that comes through a healthcare system gets a CT scan these days. So is there some valuable information in terms of the calcium score in the CT scan and atheroma score that could help us detect PAD early? So that's what we're working on. So yeah, we need to think outside the box of how to get to these patients early enough and not wait till they're CLTI.
Yeah, I want to go back to Dr. Beck's point, which I think is extremely important thing. Like some places, and we're trying to hit that way as well, to create sort of a model of this preventive medicine where we have kind of one-stop shop for clinic, where you just don't have just the vascular surgeon and, you know, the PA or nurse practitioner and maybe a podiatrist around, but also have a diabetes expert, glucose management team kind of thing. You have a social worker that's going to help these patients arrange transportation from this next visit. You have an, vascular medicine around as well. So you just have these kind of collaborative and holistic clinics where people can just come and really be addressed rather than trying to give them 5 different appointments, especially for those that have very difficult access. And there's a lot of places that are working on that model. I think could work really well for that aspect of prevention and management at that time too.
All right, we'll take one final question.
Okay. In the reports that we get, I'm wondering if VQI is going to separate some of the data out by race so that we can see if we're working on a quality of initiative, long-term follow-up 30-day, any of the medications, is there a disparity that we can actually see in front of us that we would take back to our providers? That would be number one. And then, I have not really seen this on television in quite some time, but much like stroke, heart attack, hypertensive, the silent killer, are we thinking about doing any national initiatives to try to teach people before they get to that stage? And I'll give you an example. As a kid, my mother smoked, right? I saw this ad on TV that said if she just smoked half the cigarette, she'd be better. So we went around and drew circles around half the cigarettes to try to get her to smoke. But I mean, it made an impact on me as a kid even. So are we thinking about doing something on a grander stage?
Good points. Thank you very much. We're a little bit over time. I would like to thank our panelists for an excellent discussion. I do think we may have some ideas for a national quality initiative. We'll have to ruminate on that, but that would be a grand one. So thanks again.